driving, we're talking about the workplace, maybe somebody who's driving for their workplace activities, just something that needs to be considered. Oh, I had to throw in a cartoon. Well, there's a side effect I've never seen before. Look at my pill. Again, so because it's a central nervous system depressant, somebody that's combining it with another CNS depressant, so like an opioid or alcohol, it really can be dangerous. And there are other pieces that withdrawal. If there's somebody that is on these medications and wants to get off of them, especially with the benzodiazepines, it's really important that we encourage them to be working with a provider to do it, because they can be very dangerous, especially the benzodiazepines to withdraw. You know, withdrawal for individuals, even somebody that has you know, a physical dependence. So somebody that's on an opioid for a legitimate reason, if they're on them even for a number of weeks, they're going to develop, their body will develop a physical dependence to that medication. So if they were to stop taking the medication cold turkey on their own, they're going to experience withdrawal. Now, does that mean that they have a severe substance use disorder and oh my gosh? No. That just happens on these medications. Your body develops a dependence to it. That's normal. But withdrawal, even with the physical dependence, can be really uncomfortable. You'll see some of the symptoms that we go through, and it can be traumatic for individuals. None of us wants to feel uncomfortable. We don't want to experience any of these things. So I think it's important that we're encouraging individuals to work with somebody and to not just do it on their own, so that they, and if they are having any health issues, or if maybe they are suffering, from a substance use disorder as a result of the medication, that they can get the help that they need or they can be referred. Opioids obviously relieve pain. They're affecting, they control emotion, they control the part of the brain that diminishes the painful stimulus. So again, we've kind of talked about some of the examples of them. Vicodin, most commonly prescribed for a lot of the acute pain things, dental, injury-related pain, oxycodone, which is your OxyContin, Percocet, morphine, and codeine. So they attach to proteins called opioid receptors that are located in the brain, they're located in the spinal cord, they're located in the GI tract, so really all over the body. And so when they attach, they reduce this perception of pain, which is why they're given for pain. Some of the short-term effects, the drowsiness, mental confusion, nausea, constipation, respiratory depression. Again, there's that respiratory depression piece. And then there's a euphoric response. It makes people feel good. Some of the longer-term potential effects, addiction, severe lethargy, the sleep apnea. And the sleep apnea is interesting because individuals develop apnea and they're not able to sleep. Well, what's prescribed to help people fall asleep? Yeah, a benzodiazepine, which is also a respiratory depressant. So, there are cases where you'll see both of those prescribed, but it definitely should be done under doctor's care and needs to be monitored. So again, withdrawal, restlessness, muscle and bone pain, insomnia, diarrhea, vomiting, cold flushes with goosebumps. Who wants to experience any of that? It sounds miserable. And from what I understand, it is. So again, really encouraging somebody to work with a provider if they are wanting to go off medications, so they can help with some of these symptoms. So when I'm talking about tolerance does develop rapidly to the sedating and the euphoric effects of opioids. So the sedating and the euphoria, but it develops more slowly to the pain relieving effects, which is kind of interesting. And then I put this in here again just to show you when I'm talking about the chemical makeup of here's heroin and here's OxyContin. You can see how very similar they are. I'm not a chemist, so I can't spot out all these little pieces, like my pharmacist intern could. But you can see how very similar they are. And I put that up there just so that we see that it is something we need to be aware of and that we want to be on top of. And something called opioid-induced hyperalgesia. And I just throw this in there because, again, I want you to be knowledgeable. This is not an easy issue to understand and to always know how to deal with, because they are legal prescriptions. People have them for legitimate pain and legitimate anxiety, things like that. But there is something called hyperalgesia, where individuals can actually develop an increased sensitivity to pain from being on an opioid. And that prescribers will find that if they get them off the opioid, they actually realize that they don't have pain. But it's really hard to determine, well, is the pain due to that, or is it due to the condition, or what? So prescriber's role is not easy in trying to figure all of this out. And then there's also something called pseudo-addiction. So again, I talked at the beginning about how pain is not adequately treated in our society. So somebody may exhibit, I hate the word drug seeking, but it's in here, drug seeking behavior, because they're trying to get their pain treated. So they might be going to different doctors, or they might be going to different pharmacies to get medication to alleviate their pain. And as soon as you get their pain treated adequately, those behaviors stop. So they're not suffering from a substance use disorder, they're trying to get their pain treated. And it's really hard sometimes to determine the difference. But again, I think that's where EAPs can really come in. Talking with individuals, open communication are all very important. But I just want you to be aware of these terms so to understand that it's not always a straightforward issue. It's not black and white. It's definitely not black and white. There's a lot of different facets to it. And then the last area just addresses the stimulants, increasing alertness, attention, and energy. They elevate blood pressure and heart rate and respirations versus the respiratory depressants. These elevate. And I mentioned they were Schedule IIs. You already saw that. So some of the long-term effects, again, taking high doses of some stimulants repeatedly over a short period of time can lead to feelings of hostility or paranoia. Again, that's just with some individuals. So there are some potential long-term effects on some of these medications as well. And then prevention, again, just to stress some of the prevention messaging that's really important around this issue, is that people should be monitoring their medications. And so that they know, especially the stimulant medication, the benzodiazepines and opioids, because people are stealing prescriptions. People are stealing medications. I hear it every single time I go give a presentation, I go do an exhibit. Somebody usually comes up to me and says, oh yeah, I had my medication stolen, and kids, friends, or whoever. It happens quite a bit.
I had read somewhere that the teenagers now, when they go to parties, are robbing the medicine cabinets. And
Yeah.
what they do is there's a huge bowl. They come and throw them in this one bowl.
Yeah, Skittles parties they call them, or there's a couple different names, but yeah, they will. They'll just take whatever medications, they put it in a bowl, they take a handful of the medication, and they usually swallow it with alcohol. So yeah, very dangerous practice. So I think it's important that we're doing education with employees around the issue to monitor medication. And the other thing I've heard too is stories where individuals will go back to their pharmacist and say, you did not give me all my medication. You're shorting me. Pharmacist is like, I'm not shorting you. We keep track of it all. Come to find out, someone from the home was taking the medication. And, I think we never want to think our kids are doing that, but kids are curious. Kids experiment. That's what they do. We can't assume that our kids aren't. And I like to tell this story. We had a prescription drug abuse forum a couple years ago, and had Alex Hunter, who was a former DA for Boulder. And he shares his story, which, unfortunately is, not that uncommon, where his son was attending CSU and called one night and was in Boulder and said, hey, I have a friend here, do you mind if we come over for dinner? Dad's like, of course, So they came over, and when he tells the story, he talks about how he noticed his son wasn't acting quite normal. I think his son tended to be more outgoing and gregarious, and his son kind of seemed more quiet, withdrawn. But he thought, he's in school, stressed out, really didn't think anything of it, and then, a week or so later, got the knock on the door from sheriff's office saying his son had overdosed and died. From OxyContin, and I believe it was a mixture of alcohol, but they believe that he got it from his dad's medicine cabinet. You know, his dad's like, I'm in law enforcement, I should have known, but we just don't think about it. Again, the safety, we just think they're medications, whatever, big deal. It doesn't matter. It does matter. And people, we need to be educating people to keep them locked. You know, they should be locked up. They should not be kept in your open medicine cabinet or kept on the counter. They should be locked up. And so encouraging individuals to monitor, lock up, not stockpile. And then the last piece that I'm going to talk about is the disposal piece. Did you have a comment?
Well, I was going to say, isn't there a monetary incentive too, not just kids going to take it for parties? But
Yeah. Well, and it's not just kids that are stealing medicine. You know, when I hear these stories, it could be, I've just examples of what I heard. It's service, people maybe coming in to clean the home, people coming in to fix something, open houses, people will go to open houses. You know, these are adults too. These are not just youth that are doing this. You know, there's a monetary incentive, yes, and people that might be struggling with themselves, so.
Yeah, there was an incident back east where they found a bunch of kids in the chat room. Well, I got 2 oxycodone. One of my picks were, can I get 10 Vicodins or stuff like that. They would just trade it back and forth in the chat room.
Right. Yeah, I mean, it's pretty common. It was interesting. I was at a meeting the other day, and some guy was just showing us examples because we're looking at data and how we can make data around this issue available. And he was just showing some examples. And one of the things he did is he just did it for Denver Metro, but he pulled up, I don't know how he does it, I'm not that good at data, but he had keywords in there, and he was able to pull up on the map, you know, like the picture the person put on Twitter there, you know, and their Twitter account, and these words and their comments around medications, and I was like appalled. I was like, oh my God, just hearing the comments and the conversations of people just throughout the Denver metro area about getting medications and scoring, and I was like, oh, it was very sobering. Just to see it like that. I don't know. I'm in this field, and it was an eye opener for me.
It's not just repair people. I have a client who's a pretty high-level financial advisor, and she goes into her clients' homes. She works with the elderly, and she will excuse herself to go to the bathroom and basically raid whatever she can find.
Right.
She, has been a poly drug user, so she really doesn't care what she finds in their drug cabinet, just as long as it's mood altering.
Yeah.
So,
Well, you're right. I mean, it doesn't discriminate. And I think, unfortunately with the substance use issue, there's so much stigma around it. And when we think of somebody, when we say alcoholic or somebody who's struggling with an addiction, we get this idea in our mind of, it looks like this person that's on the street, maybe homeless, holding a sign, very bedraggled. That is not what individuals, they look like you and I. They're working, they're employed, but they're just struggling with an issue. So, again, yeah, we need to break down that stigma, and that's a good reminder about that. And so just to end with it, is the Take Back. We have another Take Back event coming up. Kate's actually passing some information around about safe storage and disposal and our fact sheet. So April 26, 2014, and I'm going to put some posters up in the back. If you guys want to take any of these, the DEA does these events twice a year. There's one coming up in a couple of weeks where people can go to local law enforcement that are participating, but there's a lot of them participating all over the state, and drop off any medications, controlled or not, so any of these medications, no questions asked. It's a good opportunity for people to get rid of their controlled substances because right now, we don't have a lot of good options for that because only law enforcement can take back a controlled substance. You can't take your Percocet back to a pharmacist and say, here, it's illegal, it's a felony. The only person that can take it back is law enforcement. So we're working as a state to increase options and get like some lock boxes at some of the police stations, sheriff's departments where people can get back controlled substances. But it's an issue because we don't have a good disposal option. For the Take Back event, we ship all those medications that we get. They're taken to Utah to be incinerated, and they're a UTA certified incinerator. So. yeah.
Can you comment on the fact that a lot of these drugs, if they sit for a while, they lose their impact?
Well, they definitely do. I mean, we think that a medicine cabinet is the best place to store any medication, and it's really not. They're supposed to be stored in a cool, dry place. So really a medicine cabinet isn't, because that can break down. Being in moist environments, hotter environments can actually break down some of the medication more.
So someone could go in, say, get some Oxy out of the medicine cabinet. It's been there for a year. Somebody stopped taking it after their pain went away from a surgery, whatever. And they take one and it doesn't affect them because it's lost the potency. So they say, damn, I better take 2 or 3. And I think that's probably where you get some of your overdose.
It could be, yeah. And the other issue we see with overdose too is individuals that maybe go to jail or that go into treatment and get clean, but then maybe come out and they relapse, or they get out of jail and they start using at the same level that they left at, and but their body now has been off of this for a while and they overdose. So, you know, everybody's body reacts differently, but I think if we can just do some more education on this, have good policy in place, be talking about it, that we can really start to make a difference about it. So I'm going to have these just in the back if people want to take these to advertise the event anywhere you think you might want to advertise it. Great. And then to end with, our last take back, we had 2 of them in 2013. Colorado turned in over 39,000 pounds of medication. That's not all controlled substances, some of it's vitamins too. But that's still, when we talk about access, that's a lot of access that we have. Nationally, 695 tons. So that's all I have. You guys did a great job of asking me questions as we were going along, which I like. Any last questions at all? This is my contact information. If you have any more questions or you want to ask me something or you want electronic copies of information, I'm happy to provide that. So thank you very much. Yeah, go ahead.
Will you work with Chris about getting this posted to the EPUB website?
Sure.
That would be
definitely.
excellent.
Yes.
Thank you.
Yep, happy to provide that. Okay, thank you.
Thank you very much, Lori. I promised that she was excellent, and let's take maybe a 5-minute break. Our next speaker's here, and we'll get that all set up. But refresh your drinks, do everything.